Hello everyone, I am myself Dr. Rajesh Gubba. In this particular session, I will be discussing the very important topic in the cardiology, that is the mitral regurgitation. So mitral regurgitation, where there is leakage of the blood from left ventricle to left atrium during the LV systole, that is what is your mitral regurgitation. So for the development of mitral regurgitation, we have two important etiologies. One is acute and the other one is chronic. So acute causes, they are mainly secondary to coronary artery disease or the rupture of the papillary muscles. So all that will come under, or trauma to the chest. So all that comes under your acute MR. So chronic MR, again we classify that into the primary and as well as the secondary MR. So primary MR means the pathology is in the valve leaflets and as well as caudate tendineae. Whereas the secondary MR, the pathology is within the subjacent myocardium or the papillary muscle dysfunction. That will be the secondary MR. And what will be the clinical scenario with which the patients with mitral regurgitation present? So they usually present with palpitations, they present with dyspnea. So these are the common presentations, and these individuals, they can also have the fatigability as well. And if the severity of the MR increases, these individuals, they'll also have the features of right heart failure as well. And on examination, that is particularly on auscultation, a very, very important murmur, that is a pansystolic murmur is being heard at the apex, and that will be radiating to the axilla. And depending upon the valve, the murmur can radiate even to the base of the heart as well. So this will be the very important examination finding. And how do you investigate these individuals? That is mainly by your 2D echo, by which you will be able to assess the severity of the MR and what is the plan of action can be made out by doing the two-dimensional echocardiography. And how do you treat? So remember, asymptomatic individuals, like you can give diuretics and all. Whereas in acute MR, if it is secondary to papillary muscle rupture and all, they require immediate or emergency surgery. But for chronic MR, if the individual is asymptomatic, medical management will suffice, and there are certain indications for surgical treatment, all that we will be discussing now. So, like, this is the brief intro of overview of what exactly is the mitral regurgitation. Now, for the development of the mitral regurgitation, the pathology should be in any one of the mitral valve apparatus. That is, the pathology should be either in the leaflet or pathology should be within the mitral valve annulus, right? If there is mitral valve annular dilatation, like in case of dilated cardiomyopathy, that can result in mitral regurgitation. And pathology should be in the caudate tendineae, where the rupture of the caudate tendineae can cause the mitral regurgitation. Then papillary muscle dysfunction can cause the mitral regurgitation, and if there is pathology in the subjacent myocardium, right, if the pathology is in the subjacent myocardium, then also there can be development of the mitral regurgitation. So like in any of this valvular apparatus, if there is pathology, there can be development of the mitral regurgitation. Now, this mitral regurgitation, as I have said you, like what are the etiologies? We classify them into the one where the individual can develop an acute MR and the one where the individual can develop the chronic MR. Now, what are the etiologies that will be causing acute mitral regurgitation? Acute mitral regurgitation, it occurs secondary to acute myocardial infarction. Now, which wall of MI infarction will be causing this acute mitral regurgitation is the inferior wall MI, and as well as the anterior wall MI will be causing the acute mitral regurgitation. Why is that? Because the papillary muscles, they are located within the inferior wall and to certain extent even in the anterior wall. So if there is infarction of these walls, there can be rupture of the papillary muscles causing mitral regurgitation. And next important is the blunt trauma to the chest. Even this can cause the acute mitral regurgitation. And then infective endocarditis, causing the perforation of the valve secondary to the vegetations, will be making the individual to develop the acute MR. Okay, so these are the etiologies that will be causing the acute MR. Now you need to understand a very, very important point, that you take the papillary muscles. You have two important papillary muscles. One is the lateral papillary muscle and the other one is the medial papillary muscle. Now the point is, whenever there is an acute MI, which papillary muscle dysfunction is more common? Okay, so please remember, it is the posteromedial, right? It is the posteromedial papillary muscle involvement is the one which is most commonly affected than compared to that of the anterolateral. Okay, so why is that? The posteromedial valve involvement is like most common, then compared to that of the anterolateral papillary muscle involvement. Why? Because the posteromedial papillary muscle, it has the single blood supply, right? It has a single blood supply, whereas the anterolateral papillary muscle, this has the dual blood supply. So that is the reason why the posteromedial papillary muscle dysfunction is the one which is more prone for the development of acute mitral regurgitation. And the other one, the cause for acute MR, as we have discussed, rupture of the caudate tendinae. So rupture of caudate tendinae will cause acute on the chronic MR. So these are the etiologies that will be causing the acute mitral regurgitation. Then followed by that, the chronic mitral regurgitation. So if you take this chronic mitral regurgitation, we classify the etiologies of chronic MR into two. One is the primary MR and the other one is the secondary MR. Now, what is primary MR and what is the secondary MR? Let me tell you, in case of the primary MR, which is a degenerative disorder, in this, the pathology will be only in the mitral valve leaflets, that is anterior and as well as posterior mitral leaflets, and pathology will be in the caudate tendinae. So, if the pathology of mitral valve leaflets and caudate tendinae causing MR, that will be the primary MR. Then, what do you understand by this word secondary MR? Secondary MR, the pathology is not in the mitral valve leaflets or the pathology is not in the caudate tendinae. So what is the cause of development of the secondary MR is? It is due to left ventricular remodeling, which can occur in case of ischemic cardiomyopathy, which can occur in case of dilated cardiomyopathy, and even it can occur in hypertrophic cardiomyopathy and even in atrial fibrillation. So left ventricular remodeling can cause the secondary MR. Annular dilatation causing secondary MR, that will be seen in patients with a dilated cardiomyopathy. Next is the papillary muscle displacement causing development of the MR, that can happen in ischemic cardiomyopathy. So in ischemic cardiomyopathy, there can be papillary muscle displacement causing the development of MR, that will be secondary MR. Next is the dyssynchrony. So if there is interventricular dyssynchrony in case of dilated cardiomyopathy, that can also contribute to the development of MR, that will be the secondary MR. So dyssynchrony means what? Normally both the ventricles, they contract simultaneously, but dyssynchrony means if the left ventricle and right ventricular contraction are not simultaneous, that we call it as the dyssynchrony. And the other cause for secondary MR will be posterior leaflet tethering is also the one which is responsible for the secondary MR. Now, like we have discussed, what is the pathology for the development of the primary MR and as well as the secondary MR. But what exactly are the true etiologies causing the primary or the secondary MR? Now, you take the primary MR. The most common cause of the primary MR causing the mitral regurgitation is the mitral valve prolapse, right? Which is nothing but myxomatous degeneration of the mitral valve leaflets. And the other important etiology causing primary MR will be rheumatic fever. Next, healed infective endocarditis. There are some congenital causes which are associated with the development of the primary MR, like I'll be discussing that in detail. Next is the radiation can cause the development of the primary MR. So these are the etiologies. So the pathology will be either in the leaflet or in the caudate tendinae. Now let me try to explain to you. See, mitral valve prolapse we have discussed in detail separately in a section called as the mitral valve prolapse. But now let me tell you how this rheumatic fever is responsible for the development of the mitral regurgitation. So what will be the pathology in the rheumatic fever causing mitral regurgitation? So rheumatic mitral regurgitation, the pathology is either in the valve cusps, the pathology is either in the commissures, the pathology is in the caudate tendinae, right? Now, let me discuss like what will happen in the valve cusps in case of the rheumatic mitral regurgitation. So, the valve cusps, they become rigid, right? And there is deformity, right? There is deformity within the valve cusps, and there will be also retraction of the valve cusps. Right, there will be also retraction of the valve cusps. So that will be the abnormality within the valves. Now, what will be the abnormality within the commissures causing rheumatic mitral regurgitation? That will be commissural fusion. Right, commissural fusion is what is responsible for the development of rheumatic mitral regurgitation. Then, what will be the abnormality within the caudate tendinae causing mitral regurgitation? So, there will be shortening of the chordae tendineae, right? There will be shortening of the chordae tendineae, right? And there will be contraction of the chordae tendineae, and there will be fusion of the chordae tendineae. Okay, so this is about the pathology caused by the rheumatic fever within the chordae tendineae causing mitral regurgitation. So rheumatic fever will cause pathology within the valve cusps, commissures, and as well as chordae tendineae, ultimately causing the mitral regurgitation. And next we were discussing about the congenital anomalies causing the primary MR. That includes the atrioventricular cushion defect. And what is that atrioventricular cushion? And what is that atrioventricular cushion defects are? They are basically defect within the endocardium. So endocardial cushion defect, right? And this primary MR, it is also associated with ostium primum type of the ASD. So in ostium primum type of ASD, there will be cleft in the, right? There will be cleft in the anterior mitral leaflet. So ostium primum type of ASDs, they are associated with cleft in the anterior mitral leaflet causing the development of mitral regurgitation. And then another etiology which was causing primary MR was radiation. So even this radiation will cause pathology in the valve leaflets and as well as chordae and annulus causing mitral regurgitation. So what does the radiation do to the leaflets? To the leaflets, it will be causing the thickening of the leaflets. The radiation will be causing the retraction and as well as the calcification of the leaflets, and thereby causing the development of mitral regurgitation. And what is the pathology within the chordae and annulus which is caused by radiation is, so there will be annular dilatation, right? There will be annular dilatation which is caused by the radiation, and that will be responsible for the development of the mitral regurgitation. So these are the pathologies of the etiologies causing the primary MR, that is acute rheumatic fever, healed infective endocarditis, radiation, and as well as the congenital abnormalities and as well as mitral valve prolapse. Now coming to the secondary MR. So what exactly is the pathology for the development of secondary MR? We have discussed. That means the structures apart from the leaflets and as well as chordae tendineae, the remaining structural involvement will cause the development of secondary MR, like left ventricular remodeling, annular dilatation, papillary muscle displacement, dyssynchrony, and posterior leaflet tethering. So all these will contribute to the development of the secondary MR. Now, what are the etiologies which are responsible for the, see, these are all the pathology or the pathogenesis, how the secondary MR will lead to the development of, how the secondary causes will lead to the development of MR. Now, what exactly are the etiologies that will be causing secondary MR? One is the ischemic cardiomyopathy. See, ischemic cardiomyopathy, like what can happen? There can be papillary muscle displacement. Either you take an anterior wall MI or inferior wall MI, there can be papillary muscle displacement causing secondary MR. And another important etiology of secondary MR is the dilated cardiomyopathy. So you have to understand that in case of dilated cardiomyopathy, if the left ventricular diameter, right? So you have to understand that if the left ventricular end diastolic dimensions, if it is more than 6 centimeters, that will cause the annular dilatation of the mitral valve, and that will be responsible for the development of MR, and that is what is the pathogenesis in dilated cardiomyopathy causing mitral regurgitation. Next is the hypertrophic cardiomyopathy. See, hypertrophic cardiomyopathy, it is dynamic in nature, right? And what is the mechanism for the development of MR in hypertrophic cardiomyopathy is because of development of systolic anterior motion of the anterior mitral valve leaflet. That is what is responsible for MR in case of the hypertrophic cardiomyopathy. And next is the atrial fibrillation. See, what is the mechanism of atrial fibrillation causing secondary MR is the atrial fibrillation that is responsible for left atrial remodeling. And that is what is the mechanism for the development of mitral regurgitation. And this atrial fibrillation will also cause the annular dilatation. Right? Atrial fibrillation will also cause the annular dilatation. And that is what is another important mechanism for the development of secondary MR. So finally, what is the another important etiology that can cause the MR is the annular calcification. So even the annular calcification is also the one which is responsible for the development of mitral regurgitation. Okay, right. And what you have to understand and what you have to remember is that irrespective of the cause, right, this chronic MR, either it is primary or secondary, it is often progressive. Why? Because as the MR is happening, there is enlargement of the left atrium. And once there is enlargement of the left atrium, that places the tension on the posterior mitral leaflet. Once it places the tension in the posterior mitral leaflet, that will be pulling the posterior mitral leaflet into the left atrium. So MR keeps on progressing, and subsequently there can be development of the left ventricular dysfunction as well. Okay. So the left ventricular dysfunction, if you see, initially there will be left ventricular dilatation. Why there will be left ventricular dilatation? I'll explain to you in the hemodynamics. So left ventricular dilatation increases with regurgitation, which in turn enlarges the left atrium and as well as the left ventricle further, resulting in vicious circle. Hence the aphorism, MR begets MR. So once the individual develops mild MR, that mild MR, if it is not being treated, then that can progress to moderate and as well as the severe MR. Okay, right. Now let me try to explain to you about the left ventricular dilatation mechanism, why it happens. Now if you see this image here in the hemodynamics, like left ventricle end-diastolic volume is around 110 ml. Okay, so here in MR, when the left ventricle is contracting, what is happening? Almost like 70 ml is going into the aorta and 40 ml is going into the left atria. But left atria is in a state of left atrial relaxation. So when the left atria is in a state of left atrial relaxation, left atria should be receiving the blood from the pulmonary veins, right? So you have totally 4 pulmonary veins. Through pulmonary veins, the left atria should be receiving the blood. But in MR, what is happening? So in MR, what is happening is, along with the pulmonary venous blood, right? Along with the pulmonary venous blood, you also have the presence of the MR blood. So now thereby what will happen to your left atrial volume? The left atrial volume increases. So as the left atrial volume increases, what happens subsequently is that increased left atrial volume will return back to the left ventricle. Now once that increased left atrial volume returns back to the left ventricle, what will happen is there will be left ventricular dilatation. Right, there will be left ventricular dilatation. So the type of hypertrophy what you get in patients with mitral regurgitation is eccentric hypertrophy, right, where there is enlargement of the left ventricle, and that is the reason why even the apex of the left ventricle, it is shifted down and out in patients with MR. Okay, so you see the hemodynamics. So what is happening here? So there is leakage of the blood from left ventricle to the left atrium during the systole. So that particular leakage from left ventricle to the left atrium, it occurs throughout the systole, and that is the reason why you get what is called a pansystolic murmur. So now what has happened to the volume of the blood and as well as pressure within the left atrium? The volume of the blood and as well as pressure within the left atrium increases. Yes. Now you see the left atrial volume is grossly increased. Right, left atrial volume is grossly increased in MR. Now once this entire left atrial volume is coming back to left ventricle, what will the mitral valve behave as? Remember, the mitral valve will behave as the presence of the functional mitral stenosis. Actually, mitral stenosis is not there. It is a normal valve area which is there in MR in case of the primary MR, like 4 to 6 centimeters square. But the amount of blood which is coming from LA to LV is more than normal. So thereby the mitral valve annulus, it behaves as the functional mitral stenosis. And because of this functional mitral stenosis, right, the individual will have another important additional murmur, and that too it's a functional murmur, but that happens only in case of severe MR. What do you understand by the word severe MR? I will discuss that in 2D echo. So whenever there is severe MR, there is mid to late diastolic murmur. So this will be the functional murmur, right? This will be the functional murmur. So you see here, the large volume of the regurgitant blood again enters the left ventricle during the diastole through the mitral valve. Thus, though the left atrial pressure increases during the systole, it decreases during diastole. So the mean atrial pressure remains same in early stages. In early stages, the mean atrial pressure remains same because whatever the blood has entered into left atrium is coming back into your left ventricle. But as the severity of the MR increases, what will happen? You see here. And so in early stages, there is no increase in the pulmonary venous pressure, because whatever the blood has entered into left atrium is returning back into your left ventricle, and there is no increase in your mean atrial pressure. But when the left ventricle fails in case of severe MR, when left ventricle fails in severe MR, what will happen? The left ventricular end diastolic pressure increases. When left ventricular end diastolic pressure increases, you see the left ventricle is not in a position to receive that large quantity of the blood which is coming from the left atrium. So increase in left atrium and pulmonary venous pressure occurs. So once your left ventricular end diastolic pressure occurs, LA cannot send the blood to LV comfortably. So LA pressure increases. And as the mean left atrial pressure increases, that will be transmitted to pulmonary veins, because you don't have any particular valves between the pulmonary veins and as well as the left atrium. So the pressure is reverted back into pulmonary veins, and thereby the pulmonary venous pressure increases. And subsequently, what will happen? The pulmonary capillary wedge pressure increases and there will be pulmonary congestion. And as the severity further increases, there will be increase in the pressure even within the pulmonary arteries, causing pulmonary hypertension. So once there is pulmonary hypertension, there can be functional pulmonary regurgitation, and subsequently there can be development of right ventricular failure as well. Okay, so this is about the hemodynamics that will be happening in case of the mitral regurgitation. So in early stages, the individual will not have any pulmonary congestion, like in case of mild to moderate MR. But as the severity of the MR increases, in case of severe MR, once there is left ventricular dysfunction, that is the point when there can be pulmonary congestion, where the patient will present with dyspnea. So what you have to understand from the hemodynamics is that the patient will become symptomatic only in case of the severe cases of MR at rest. Whereas in mild to moderate MR, usually at rest, the individual is asymptomatic. The individual will become symptomatic in case of mild to moderate MR only on exertion. Okay. Now, let me discuss the clinical features in patients with the mitral regurgitation. So, you take acute severe MR, which will be occurring secondary to coronary artery disease. In acute severe MR, you see acute severe MR. That means large quantity of the blood is moving from ventricle to the left atrium. Now, the left atrium will again send back that large quantity of the blood to LV. So LV is not prepared. In case of acute severe MR, the left ventricle is not completely prepared to receive that large quantity of the blood from the left atrium. So the LV fails immediately. So once the LV fails immediately in case of acute severe MR, the patient will present with acute pulmonary edema. So once there is acute pulmonary edema, right, once there is acute pulmonary edema, these patients, they should have dyspnea, and that too it should be acute onset dyspnea. Whereas you take in case of mild to moderate MR. See, mild to moderate MR, as I have said you previously also, usually they are asymptomatic. Right, in early stages or in resting stage, they are asymptomatic. The LV volume overload is well tolerated in case of mild to moderate MR, but only on exertion, right? Only on exertion, there can be development of dyspnea. See, what happens is, upon exertion, there will be development of tachycardia. So once there is tachycardia, the diastolic filling time of the left ventricle decreases. So as the diastolic filling time of the left ventricle decreases in case of tachycardia, the large quantity of the blood which is there in LA in case of MR will not be returning back to LV, because the diastolic filling time is decreased. So what will happen to your pressure within the LA now? The pressure within the LA increases, and that will be reverting back to pulmonary vein, causing pulmonary congestion, causing dyspnea. So the dyspnea will be there only on exertion, and on exertion, what is happening? The diastolic filling time is decreasing. So that is the reason why your LV cardiac output also decreases. So once the LV cardiac output decreases, these patients, they will have fatigue, right? And in early stages, these patients, they also have orthopnea, right, where the individual will have dyspnea in supine position. Okay, right. Now you take in case of the chronic severe MR. So in case of chronic severe MR, please remember, these patients, they will develop dyspnea at rest, or the individual will have the development of dyspnea with minimal exertion. That will be your chronic severe MR. And not only that, in case of chronic severe MR, these patients will also develop the palpitations. What is the mechanism of the development of palpitations is, in case of chronic severe MR, there is enlargement of your left atrium, and this enlarged left atrium will be arrhythmogenic, and that will result in the atrial fibrillation. So because of the development of atrial fibrillation, these patients, they present with the palpitations. Okay, now as the severity of the MR increases after the pulmonary congestion, once the pressure increases in the pulmonary artery causing pulmonary hypertension, in the later stages, these patients will also have the features of right-sided heart failure. And what will be the features of the right-sided heart failure? That includes raised JVP. That is the earliest manifestation in right-sided heart failure. Then the next important feature is tender hepatomegaly. Right? The next important feature is tender hepatomegaly, because the inferior vena cava pressure also increases in case of right heart failure. So there will be stretch of the Glissen's capsule around the liver, because liver is not able to send the blood into the inferior vena cava. So thereby there will be tender hepatomegaly. So these patients, they also develop pedal edema. They also can develop portal hypertension. And secondary to portal hypertension, these patients can also have the development of the ascites. Right, they also have the tendency of development of ascites. And as the severity of right-sided heart failure, or as the pulmonary artery pressure further increases, there can be functional pulmonary regurgitation, and there can be also functional tricuspid regurgitation as well. And these patients, they will also have the because of the pulmonary hypertension only, all these manifestations will develop. Now these are the clinical features that you will see in case of MR depending upon the severity of the MR. Now coming to the examination findings. So you take in case of chronic severe mitral regurgitation. Chronic severe mitral regurgitation, the blood pressure, right? The blood pressure, that is usually normal. Okay. But only what will happen to your carotid pulses, when you examine the carotid arterial pulse, that will show a sharp low volume upstroke. Right, sharp low volume upstroke. Okay, because to certain extent the cardiac output is not good, because once there is chronic severe mitral regurgitation, there is left ventricular dysfunction. So that is the reason why once the cardiac output decreases, there can be a low volume upstroke, right? And upon palpation, what is that you will observe? So this sharp low volume upstroke is mainly because of decrease in the cardiac output. So upon palpation in patients with mitral regurgitation, at the apex, you will feel for a systolic thrill, right? So what do you understand by the word thrill? That is nothing but palpable murmur, and this murmur is being heard during the systole. So that is the reason why this systolic thrill is being felt at the apex of the precordium. And how will be the apex? That will be hyperdynamic type of apical impulse. Right, so that will be hyperdynamic type of the apical impulse, and you will also be able to make out the presence of the S3. Why? Because the LA pressure is high, so there is first rapid filling, and that rapid filling is because of increased volume of the blood in the left atrium, because left atrium has pulmonary venous and as well as the MR blood. So thereby you will have a palpable S3 as well. And how will be the apex? Apex, it is shifted down and out. Right? Apex, it is shifted laterally. So these are the palpatory findings that you will come across in patients with the mitral regurgitation. Then you take in case of the acute mitral regurgitation. See, whatever we have discussed, this is the chronic severe MR. Whereas you take in case of the acute mitral regurgitation. In acute mitral regurgitation, the blood pressure is being reduced. Why? Because in acute MR, what did we discuss? The left ventricle will land up in severe left ventricular dysfunction. Once there is severe left ventricular dysfunction, the cardiac output is grossly reduced. So thereby the blood pressure is also being reduced. Now, what will happen to the JVP? JVP will be increased, because acute MR will subsequently lead to the right heart failure. So the JVP will be elevated and it is being exaggerated as well. And how will be the apical impulse? Apical impulse will be in the normal place. It is not shifted down and out, because for the shifting of the apical impulse down and out, there should be left ventricular dilatation. But in acute MR, you don't have left ventricular dilatation. The left ventricle is not prepared to receive that large quantity of the blood from left atrium. Right? So the apical impulse is not displaced in case of the acute MR. And you will have the signs of the pulmonary congestion, that is because of pulmonary edema. So where you have bilateral basal crepitations over the lungs, and as the severity of the pulmonary edema increases, the crepitations can be present all over the lung fields. So that is about the examination findings in patients with acute MR. Now, coming to the auscultation, that is a very, very important part of the examination in case of MR. So how will be the first heart sound? The first heart sound, it will be soft or it will be absent. Now, why is that the first heart sound is being soft or absent is because the leaflet coaptation is not occurring completely. That means the complete closure of the leaflets is not occurring in case of MR, and that is the reason why there is leakage of the blood from left ventricle to the left atrium. So because there is incomplete coaptation of the anterior and posterior mitral leaflet, the first heart sound, it will be soft or absent. Then you take the second heart sound. Right? You take the second heart sound. So if you take the second heart sound, you have a wide split S2. Right, you have a wide split S2. Now, why is that you have the presence of the wide split S2 is because, see, what will happen to your left ventricular cardiac output or left ventricular stroke volume in MR? Left ventricular stroke volume is reduced. So, thereby, the A2 will be early. Right, thereby, the A2 will be early. So, once the A2 is early, then compared to normal, what will happen to the split of S2? You will have wide pathological split, wide split. You will have A2 and P2, but the gap between A2 and P2 is more than normal, right? And in the systole, right, what is that you will listen? You will listen a murmur. And this particular murmur, it is the pansystolic murmur. And this pansystolic murmur is being heard at the apex. Right, this pansystolic murmur is being heard at the apex. Now, after S2, then comes the diastolic phase. So, in the diastolic, you have many additional sounds. So, one is you will listen S3, that is third heart sound is being heard because large volume of the blood is returning back to LV, that too with a greater force, and thereby you will have, pathological S3, right, because of excessive rapid filling of the left ventricle in the first phase of the diastole. Now, what will be the duration between your S2 and S3? So, your S3, which is a low pitched sound, right, which is being heard at the apex, which require the bell of the stethoscope, the duration between your S2 and as well as your S3 is around 0.12 to 0.17 seconds. So that will be the duration between your S2 and as well as the S3, right? So, and the presence of S3, always remember that signifies, right, that signifies the left ventricular dysfunction. That signifies left ventricular dysfunction. Okay. Now, after this S3, the another point is you will listen a mid-diastolic murmur. Right? You will listen a mid-diastolic murmur. Now, what is the cause for the mid-diastolic murmur? Just now I have explained to you that the amount of blood which is there in the left atrium in case of MR is more than normal. So, when left atria is sending the blood into left ventricle, it is the large volume of the blood which is passing through the normal mitral valve annulus. So, the normal mitral valve annulus will behave as functional mitral stenosis, and thereby the individual will have a mid-diastolic murmur. And this particular mid-diastolic murmur, it is short, rumbling murmur. Right, it is a short rumbling murmur. Okay, even though there is absence of the structural MS, still there can be the presence of the mid-diastolic murmur. And the next important is you will listen the presence of S4 as well. See, presence of S4, presence of S3, presence of mid-diastolic murmur. So all these, right, they tell that the individual is having severe MR. Okay, so the presence of S4 tells that the individual is having a very severe MR. So now what is the mechanism for the development of the S4? The S4, again the same story, right? What has happened to the left atrial pressure in case of left ventricular dysfunction? The left atrial pressure is elevated. So once the left atrial pressure is elevated, if the left atrium has to send the blood into left ventricle, left atrium has to contract very strongly, and thereby because of a stronger left atrial contraction, you will have the presence of a pathological S4. And this pathological S4 can also be seen even in case of the acute MR, right? Because in acute MR, there is development of significant left ventricular dysfunction. So presence of S4 or the presence of S3 tells you that the individual has developed significant left ventricular dysfunction. Okay. Now, followed by that, the discussion about the murmur. So you take in acute MR, the duration of the murmur is not the same like what you see in case of the chronic mitral regurgitation. You take in case of the acute mitral regurgitation, it is a short systolic murmur. Right, it is the short systolic murmur, and this short systolic murmur is being heard only in the early part of the systole. Right, it is being heard only in the early part of the systole. Right, this murmur of the acute mitral regurgitation, it stops at the mid part of the systole. Now, what is the reason? Again, you see in acute MR there is left ventricular dysfunction. So left ventricle contracts, some amount of blood enters into left atrium, and the left ventricle is failed now. In case of acute MR, there is left ventricular dysfunction. So further contraction of the left ventricle does not occur, and further movement of the blood in the mid and as well as later part of the systole into left atrium will not be there because of left ventricular dysfunction. So because of left ventricular dysfunction in case of acute MR, the blood will be leaking from LV to LA only in the early part of the systole, and thereby you get a short systolic murmur that will be that to early systolic murmur. Occasionally there can be early to mid systolic murmurs, but mostly it is early systolic murmur that you see in case of the acute mitral regurgitation. Then in case of chronic mitral regurgitation, the murmur that you will listen is the pansystolic murmur, and this particular pansystolic murmur, it will be of grade 3/6, and it can even go to 4/6, 5/6, and even 6/6 as well. But this particular murmur, it is being heard at the apex of the precordium, right? And what is the character of the murmur? It is decrescendo in nature, right? It is decrescendo in nature. Now, to where the murmur will be radiating. So it all depends upon which leaflet is having the abnormality. Like for suppose, if the individual is having the pathology in the anterior mitral leaflet, then the murmur from the apex, it is being radiating to, it will radiate to the axilla. Right, it will radiate to the axilla. So just remember A for A. Whereas if the pathology is in the posterior mitral leaflet causing mitral regurgitation, in such case, what will happen is the regurgitant jet it becomes eccentric. Okay, regurgitant jet, it becomes eccentric, and this particular regurgitant jet, it is directed anteriorly and it strikes the LA wall. Right, it strikes the LA wall adjacent to the aortic root. So here the systolic murmur or the regurgitant jet, it is radiating to the base of the heart. Whereas in anterior mitral leaflet abnormality, the murmur is radiating to the axilla. Whereas posterior mitral leaflet abnormality, you know, the murmur is radiating to or transmitting to the base of the heart. Okay, so that is a very, very important point. Now, the another auscultatory finding is the quality of the MR murmur if there is ruptured chordae tendineae. So if the quality of the MR murmur, if there is ruptured chordae tendineae, you will listen a cooing or seagull quality. Right, cooing or the seagull quality. That is what you will have if there is ruptured chordae. And if there is flail leaflet, then in such case, like what will be the quality of the murmur? That will be musical quality. Okay, so that is about the auscultation. So to summarize auscultation, first heart sound will be soft or absent. Second heart sound, the A2 will be early, and thereby you will have wide split second heart sound. And even your P2 will be loud whenever there is development of pulmonary hypertension. And in the diastole between S2 and S1, you will listen S3, you will listen the mid diastolic murmur that tells you severe MR, and then you will also listen S4. And next very important murmur of the MR is the pansystolic murmur. And this pansystolic murmur, it is being heard at the apex. It is decrescendo in nature. and this particular murmur, it will be radiating to the axilla if there is pathology in the anterior mitral leaflet. But if the pathology is in the posterior mitral leaflet, the jet will be eccentric and it will be moving anteriorly towards the base of the heart. So the murmur will be radiating towards the base of the heart if the pathology is in the posterior mitral leaflet. Then coming to the dynamic auscultation of the MR murmur. So you need to know when will the intensity of the MR murmur increases and when will the intensity of the MR murmur reduces. So the intensity of the MR murmur increases by isometric exercises. Right, the intensity of the MR murmur increases upon isometric exercises, that is upon doing the hand grip. Right, upon doing the hand grip, the MR murmur increases. Okay, that is the systolic murmur of chronic MR increases. But the MR murmur, it will be reduced when the LV volume reduces. That is when the venous return reduces, LV volume also reduces. So when you do the Valsalva, so upon doing the Valsalva, the venous return to the right side decreases and subsequently the LV volume reduces. So thereby the volume of the blood which is regurgitating from the LV to LA will be reduced. So the intensity of the murmur is also reduced. So please remember, with isometric exercises, the MR murmur increases like hand grip, and with the Valsalva maneuver, the MR murmur decreases in intensity. So this is about the examination findings in patients with the mitral regurgitation. So in the laboratory examination or the investigations in patients with MR, the investigations which are required is the ECG, then chest X-ray, then 2D echo, then cardiac catheterization. So what will be the first line investigation? The first line investigation, definitely it will be 2D echo. But what is the investigation which is confirmatory? The confirmatory investigation will be cardiac catheterization. But this cardiac catheterization, it is an invasive procedure we rarely do for assessing the diagnosis of MR or for assessing the severity of MR. Now let me discuss about the ECG first in patients with the mitral regurgitation. So first and foremost, what is happening? There is left atrial enlargement. So once there is left atrial enlargement, so the abnormality in the P wave that you will have is the P mitral. To call it as P mitral, what should happen to the duration of the P wave? The duration of the P wave, this should be more than 120 milliseconds. Right? This should be more than 120 milliseconds. That is what is called P mitral. Then when there is severe pulmonary hypertension causing the right ventricular hypertrophy and subsequently causing the right atrial enlargement, then these patients, they also have the P pulmonale. So what do you understand by the word P pulmonale? The amplitude of the P wave will be more than 2.5 mm. Right, the amplitude of the P wave will be more than 2.5 mm. Now, whenever there is left atrial enlargement, this enlarged left atrium will be arrhythmogenic, and thereby there will be development of the atrial fibrillation. So here there will be absent P wave. Right, there is no P wave. And how will be the rhythm in these individuals? The rhythm will be the irregular rhythm. Right, the rhythm what you will have is irregular rhythm, and there is no P wave in case of the atrial fibrillation. Then subsequently in patients with severe MR, there will be volume overload of the LV causing the eccentric hypertrophy. So whenever there is volume overload of the LV, what is the abnormality in the ECG that you will observe is, you will observe the presence of the deep Q waves, right, presence of the deep Q waves in the precordial leads. That is from V3 to V6, you will have deep Q waves, and along with that you will have the features of the left ventricular hypertrophy. So what is that features of left ventricular hypertrophy? That it should satisfy the Sokolov-Lyon criteria, that is SV1 plus RV6 should be more than 35 mm, and along with that there will be deep Q waves. So these are the ECG changes that you will observe in patients with the mitral regurgitation, right? Then you should know like what will be the abnormality within the echocardiography. So this is a first line investigation. So it will tell you whether the MR is there or not, and it will also tell you what is the mechanism of development of MR, or what is the etiology that is causing MR. Is it like primary MR, like the pathology is in the mitral valve leaflets or chordate tendineae, or the pathology is like secondary MR, like dilated cardiomyopathy, ischemic cardiomyopathy, or atrial fibrillation. So echocardiogram will not only diagnose the MR, it will also tell you about like what is the etiology of the MR. And not only that, in the echocardiography, you will be able to make out like what is the quantity of the regurgitant volume. So how much amount of the blood is entering into the LA from LV. Then depending upon the regurgitant volume also, we can assess the severity of the mitral regurgitation. Not only regurgitant volume, that is the regurgitant fraction also tells you the severity of the MR. Then the other parameters that can be made out in the echocardiography in case of MR is, it will tell you if there is development of pulmonary hypertension, and it will also tell you if there is features of development of right ventricular failure. So accordingly, like we have the gradings of the MR in the 2D echo. So now what all we look for? We look for the valve anatomy and as well as the valve hemodynamics in the 2D echo. So in the valve anatomy, we look for coaptation. Is the valve completely closing or not? And is the valve thickened or not? Like in case of rheumatic, the valve is being thickened, or in case of radiation causing mitral regurgitation, the valve is thickened. So we need to look for the valve thickening also. And in the valve hemodynamics, what all we need to check for? The jet area. I'll show you what is the jet area. Then presence of vena contracta. What exactly is the vena contracta also I will show you. Then what is the regurgitant volume and what is the regurgitant fraction. So all that we will be able to make out in the hemodynamics. Now based on this, like how will you assess the severity of the MR? Let me tell you. Now, so this is the regurgitant jet, right? So this blood which is like mixed color. Okay. So this is the regurgitant jet. Now what is the vena contracta? Vena contracta is, it is the narrowest portion of the regurgitant jet. That is what is called as the vena contracta. So I'll show you that. You see here. Yeah. So this is the vena contracta. Okay. So narrowest, so this is your LV, right? This is LV and this is LA. So the blood is regurgitating from LV to LA. So in this entire regurgitant jet, whatever the narrowest portion is there, that is what is called as the vena contracta. Now, how will you classify the severity of MR is, number one, at risk of development of mitral regurgitation. Like who are those individuals? Those patients with coronary artery disease, those patients with dilated cardiomyopathy, those patients with atrial fibrillation. So they are classified as grade A, that is at risk of MR. Whereas grade B is like the MR is progressing, that is from mild to moderate or moderate to severe. Then severe MR, but the individual is asymptomatic. Then finally symptomatic severe MR. So this is how we will grade the severity of the MR, and in that we need to check for the valve anatomy and as well as the valve hemodynamics, and what will be the changes. Accordingly we will assess the grading. So you take in case of grade A, these individuals, they are at risk of development of MR. So what is at risk? That is either coronary artery disease or the dilated cardiomyopathy or hypertrophic cardiomyopathy. Now what will be the valve hemodynamics in case of at risk of MR? Valve hemodynamics, remember there is no MR jet, or there is a small central jet area of less than 20% of the left atrium. So the quantity of the MR here, it will be less than 20% of the left atrium. And how much will be the vena contracta in case of the individuals at risk of MR? The vena contracta will be less than 0.3 centimeters. Then what will be the cardiac findings? You will observe that there is normal or mildly dilated LV size with fixed or regional wall motion abnormality. Okay. So this will be the associated cardiac finding. So what is very, very important to call it as at risk of MR? The individual should be having risk factors like coronary artery disease or dilated cardiomyopathy, and the regurgitant jet, it should be occupying 20% of the LA, and vena contracta should be less than 0.3 centimeters. And the associated cardiac findings is that there will be mildly dilated LV size. Then these individuals, they'll have the symptoms due to coronary artery disease or the dilated cardiomyopathy. And the next is the progressive MR, right? The next is the progressive MR. So if you take the progressive MR, right, in these individuals, the effective regurgitant orifice, it is less than 0.4 centimeter square. The regurgitant volume should be less than 60 ml. regurgitant fraction should be less than 50%. So these are the criteria to call it as the progressive MR. And in these individuals, there will be regional wall motion abnormality, right, with reduced LV systolic function. That means these individuals will have heart failure with reduced ejection fraction. So what are important points to call it as progressive MR? Effective regurgitant orifice less than 0.4 centimeter square, regurgitant volume less than 60 ml, regurgitant fraction is less than 50%. Then you take in case of the asymptomatic severe MR. In asymptomatic severe MR, the effective regurgitant orifice is more than or equal to 0.4 centimeter square. In case of progressive, less than 0.4. And regurgitant volume should be more than 60 ml. Whereas here in case of progressive, it is less than 60 ml. Whereas in asymptomatic severe, it is more than 60 ml. Then regurgitant fraction should be less than 50%. So now how will you differentiate asymptomatic severe MR from symptomatic severe MR is the only point of difference. So you take in case of the symptomatic severe MR. In case of symptomatic severe MR, the regurgitant fraction is more than or equal to 50%. In asymptomatic severe MR, less than 50%. Whereas in symptomatic severe MR, everything will be same. The effective regurgitant orifice is more than 0.4 centimeter square. Regurgitant volume is more than or equal to 60 ml and regurgitant fraction is more than or equal to 50%. And these individuals, they will also have regional wall motion abnormality with left ventricular systolic dysfunction. So this is about the 2D echo in patients with the mitral regurgitation. So you have to look for the valve abnormalities and as well as the hemodynamics. Okay. Then following that, you need to know about the chest X-ray findings in patients with the mitral regurgitation. See here, the LA and as well as the LV. These are the dominant chambers in case of the chronic MR. So in chronic MR, the dominant chambers are the LA and as well as the LV. So now this LA, it is massively enlarged, that forms the right heart border. Right. So in the right parasternal area, whatever you see, you will see the shadow of the left atrium. Normally you don't see, because normally the left atrium is retrosternal. But whenever left atrium is enlarged, that forms the right heart border of the cardiac silhouette. And the other changes that you will observe is the features of the pulmonary venous congestion. So what will be the features of the pulmonary venous congestion? Right, where the individual will have the presence of the Kerley B lines. Right, where the individual will have the presence of Kerley B lines. So Kerley B lines is nothing but the presence of the interstitial edema. Right, and these Kerley B lines you will observe at the base of the lung. Right, you will observe that at the base of the lung. Okay, so that is about the Kerley B lines. And in case of rheumatic, in long-standing rheumatic, you can observe even the calcification of the mitral valve. But this calcification of the mitral valve, right, this calcification of the mitral valve, you can visualize best in the lateral view of the chest X-ray. So in the lateral view of the chest X-ray, if there is calcification secondary to rheumatic, that you will be able to make out. And not only rheumatic, even the radiation induced thickening of the valve, that can also be made out in the lateral view of the chest X-ray. Right. Whereas you take in case of acute severe MR. So in acute severe MR, like what will be the chest X-ray? Acute severe MR, you will observe the presence of the pulmonary edema. Right. So you will have the pulmonary congestion. So you will have the Kerley B lines, you will have the alveolar infiltrates, and there can be even development of the pleural effusion as well. Okay. So that is about the features of the chest X-ray in case of acute severe MR. Then coming to the treatment. So we have discussed the investigation, that is ECG, 2D echo and as well as the chest X-ray. Then the treatment. So treatment completely depends upon whether it is acute mitral regurgitation or the chronic mitral regurgitation. For suppose if the individual has acute mitral regurgitation secondary to papillary muscle rupture or secondary to the MI, then in such case, these patients, they require urgent stabilization. Right, they require the urgent stabilization, and these individuals, they also require urgent surgery as well. Okay, so urgent stabilization and as well as the urgent surgery. Now what do you understand by the word the urgent stabilization? See, these patients have developed pulmonary edema, so for that you need to give the diuretics, right, like furosemide, and you can give the intravenous vasodilators. So these intravenous vasodilators, they include the nitroglycerin, right? They include the nitroglycerin, okay? And these patients, they may also require mechanical support, right? They may also require mechanical support as needed, okay? So this is like the treatment in case of the acute mitral regurgitation. So number one, urgent stabilization. Number two, urgent surgery, right? Urgent surgery. So these are very, very important in case of acute MR. Whereas you take in case of chronic mitral regurgitation. In chronic mitral regurgitation, two important things. One, these patients, they require guideline directed medical therapy for heart failure. And if the individual develops the atrial fibrillation, they will be requiring anticoagulation depending upon CHA2DS2 VAS scoring system. Now, what is this guideline directed medical therapy for heart failure? So, if the individual is having chronic severe MR causing left ventricular dysfunction, then the medical management includes the diuretics that will reduce the pulmonary edema and the other drugs which will reduce the mortality and which will prevent the cardiac remodeling. So what are those drugs? Those drugs include the beta blockers. Those drugs include the AC inhibitors or angiotensin receptor blockers. Those drugs include the aldosterone antagonists. So these drugs, they will reduce the mortality and they will prevent the cardiac remodeling. And that is what is your guideline directed therapy for the heart failure. So diuretics for congestion, beta blockers, ACE inhibitors or ARBs, and next is, this is the new drug which will improve the ejection fraction. That is ARNI. What is that ARNI? The angiotensin receptor blocker that we give is valsartan, right? And neprilysin inhibitor that we give is the sacubitril. This particular combination has been shown to improve the ejection fraction if given in patients with heart failure with reduced ejection fraction. Then mineralocorticoid receptor antagonist, that is aldosterone antagonist like spironolactone or eplerenone, and these SGLT2 inhibitors which are actually given in the treatment of diabetes mellitus, that is dapagliflozin or empagliflozin, they are being found to be beneficial in heart failure with reduced ejection fraction. And if the individual has developed or if the individual is having dilated cardiomyopathy causing secondary MR, the intervention that can be done is the CRT, cardiac resynchronization therapy has to be done if there is dysynchrony and that is being manifested in the ECG with wide QRS complexes. Then you need to do CRT for dilated cardiomyopathy, right? Now coming to this anticoagulants. So anticoagulants you have to give if the individual develops the atrial fibrillation, and the preferred anticoagulant is like warfarin, right? And if the mitral regurgitation is not secondary to rheumatic, then you can give newer oral anticoagulants, right? Newer oral anticoagulants or direct oral agents can be given. What are those direct oral agents? That is dabigatran, rivaroxaban, apixaban, endoxaban. These should be given, right? NOAC should be given if there is no rheumatic origin of the mitral regurgitation. So, but please remember, this direct oral agents should not be used if moderate to severe rheumatic mitral stenosis is also present. If rheumatic component is there, please don't give this NOACs. And when will you give this anticoagulants? If suppose the CHA2DS2 VAS scoring system, if it is more than or equal to 2, and also checking the Hess-Bled score for the bleeding risk, then we need to supplement the anticoagulation in these individuals. What is the purpose? Why is that you need to give? Because in atrial fibrillation, there is chance of thrombus formation within the left atrial appendage. And this thrombus which is formed within the left atrial appendage, it can shower an emboli causing thromboembolic stroke. So for that purpose, you need to give anticoagulation. Then what about the cardioversion? See, that is cardioversion is nothing but the converting that into sinus rhythm. So converting that into sinus rhythm, it depends upon the clinical context of the individual, and it completely depends upon the atrial fibrillation chronicity, and it completely depends upon the left atrial size. If the individual is like hemodynamically unstable, then you can do electrical cardioversion, right? Electrical cardioversion should be done if the individual is hemodynamically unstable. Now, in which group of individuals with mitral regurgitation you give the infective endocarditis prophylaxis is those patients who have past history of infective endocarditis and now developed mitral regurgitation. In them, you need to give antibiotic prophylaxis for the infective endocarditis. then those patients who are having asymptomatic severe MR, what is the very important advice that you will give is, these patients, they should avoid isometric form of exercises. Right, they should avoid isometric form of the exercises. So this is about the medical management. So basically diuretics, and as well as your GDMT also includes beta blockers, ACE inhibitors or ARBs, aldosterone receptor antagonists, SGLT2 inhibitors. Then coming to the surgical treatment. So in between these two, valve repair and as well as the valve replacement, which is being more preferred? So the risk is significantly lower for the valve repair than compared to that of the valve replacement, right? So the risk is less for the primary valve repair than compared to that of the valve replacement, right? Now, what is the repair that you do? The repair that we do within the valve is the reconstruction of the valve, and then we do the insertion of the annuloplasty ring, right? Insertion of the annuloplasty ring. So this is the valve repair that we do in case of the mitral regurgitation. So now what is the advantages of repair over the replacement? See, when you do a replacement, there is chance of the clot formation. So why? Because it's a metallic valve or it's a prosthetic valve. There is risk of the thrombus formation. So when you do only valve repair without valve replacement, there is reduced incidence of there is reduced incidence of thromboembolic events. And the another important advantage is that this mechanical valves or metallic valves, whenever the blood is passing through that metallic valves, there can be hemolysis. So when you just do only repair without replacement, there is reduced hemorrhagic complications. Right, there is reduced incidence of the hemorrhagic complications. Okay, and the next important is the valve failure necessitating the valve replacement is required if there is bioprosthetic valve. So you take in elderly individuals. In elderly individuals, we place bioprosthetic valves. We don't put the metallic valves. So when there is bioprosthetic valve in later stages, after 10 to 15 years, there is the bioprosthetic valve failure will be there. So where you need to replace with a fresh valve. So these particular complications can be reduced if you do only valve repair, right? If you do only valve repair, okay, right. And not only that, the mitral valve repair or the valvuloplasty, it maintains the LV function to a relatively greater degree than compared to that of the valve replacement. So LV function is relatively maintained with valve repair. Okay. Now, you should know what are the indications for surgery. Either you take valve repair or you take valve replacement. What are the indications? First and foremost, without any doubt, symptomatic severe MR, right? Chronic severe symptomatic MR. That's definitely class 1 indication for the valve repair or the valve replacement. Now, in asymptomatic MR, when will you do the repair or replacement? If there is left ventricular dysfunction and the ejection fraction of the individual is reduced to less than or equal to 60%, it's an indication for the valve replacement or valve repair. And if the LV end systolic diameter, if it is increased to more than 40 mm, it's an indication for the valve repair or valve replacement. And on serial 2D echo, if there is progressive decrease in the ejection fraction. So in the sense, like in the previous visit, right, 6 months back, the ejection fraction was something around 65%. And the next visit, it has become 62%. And the next visit, it has become 60%. So it's an indication for valve replacement or valve repair, even though the individual is asymptomatic, okay, right? Or if there is increase in LV end systolic diameter upon the serial echo, then that is also indication for valve repair or the valve replacement, okay? So this is about the indications when you should do valve repair or the valve replacement. Then what are the other forms of surgery for atrial fibrillation. So you take atrial fibrillation, like we need to give anticoagulants, we need to give beta blockers, and we need to do medical cardioversion. But if the individual is refractory to medical management, then what are the surgical options for the atrial fibrillation? One is the maze procedure. So what actually is the maze procedure? The surgeon, what he does is, right, he creates a pattern of scar tissue. Right, he creates a pattern of the scar tissue where in the upper chambers of the heart, that is within the atria, the surgeon will create the scar tissue. Now, upon creating the scar tissue, so how is the scar tissue being created? Now, the surgeon, like, he will, with the help of a device, he will give heat and cold energy. Continuously supplementing this heat and cold energy will result in the formation of the scar within the left atrium. And this particular scar tissue does not conduct this scar tissue does not conduct the electricity. So thereby, the atrial fibrillation can be aborted. So you can just see here. So this green color, that is your cryoablation, right? So you have the dotted lines where the radio frequency or the cryoablation is given, right? Incision is like, this is the point where the incision has been given. Okay, so this is like creating the scar tissue. And the other options of surgical treatment in case of the atrial fibrillation is the radio frequency isolation. So radio frequency isolation of the pulmonary veins has to be done, and that is also one of the option for aborting or reducing the attacks of the atrial fibrillation. And next thing is the left atrial appendage should be amputated. Why? Because it is the left atrial appendage that is the seat for thrombus. So that is the reason why if the individual is having the history of recurrent thromboembolism, then the left atrial appendage has to be amputated, right? So that is about the surgical repair for the atrial fibrillation. Then coming to the surgical repair in case of the secondary MR. Say surgical management of patients with secondary MR, it is complicated. It is not the easy thing. So if the MR has developed like secondary to ischemia, that is coronary artery disease, then along with the mitral valve repair or along with mitral valve replacement, these patients, they also have to undergo coronary artery revascularization. Right, these patients parallelly they have to undergo the coronary artery revascularization as well. Now, like, what are the current surgical practice for the ischemic MR doing the repair? The current surgical practice includes either annuloplasty repair. You have to do with annuloplasty repair, right? You need to put an annuloplasty ring, right? And this annuloplasty ring, it should be, right, or it should be undersized, and it should be a rigid ring, and cord sparing, right? Cord sparing valve replacement should be done for those individuals who have moderate to greater degrees of MR. So that is about the annuloplasty, right? That is what we do in case of the ischemic MR. So the ring what we keep is an undersized rigid ring or cord sparing valve replacement for the patients with moderate or greater degrees of MR. And the point is, the valve repair for ischemic MR is associated with lower perioperative mortality rate than compared to that of the valve replacement. But this valve repair in case of ischemic MR, it is associated with recurrent mitral regurgitation over time. So that is the reason why mitral valve replacement is being preferred in case of ischemic MR than compared to that of the mitral valve repair. Okay, so that is about the treatment of the secondary MR secondary to the ischemia, right? Next, then for suppose because of the ischemia developing MR, the ejection fraction has reduced to less than 30%. So in these individuals, the risk of surgery is very high. right? There is very high surgical mortality and you have to explain to the patient. And even the recovery of the LV, right? Recovery of the LV is not very easy and it will be almost incomplete. So the ejection fraction will not return back to 60% if the ischemic MR causing ejection fraction reducing to 30%. And even the long-term survival of the individual is also reduced in case of ischemic MR with ejection fraction less than 30%. Okay. Next, then what about the dilated cardiomyopathy? What is the surgery that you do in case of secondary MR, secondary to dilated cardiomyopathy? So here, these patients, definitely you have to give guideline directed medical therapy, that is your diuretics, beta blockers, ACE inhibitors, ARBs, then angiotensin receptor blockers. Along with that, you also need to plan the surgical repair. That is, mitral valve replacement has to be done, right? But the point is, even by doing the surgical valve repair in case of dilated cardiomyopathy, the individual is not going to become completely asymptomatic because it is a dilated chambers, right, where the LV has become completely remodeled. So to revert back to normal, it becomes very, very difficult. And you take in case of the acute severe MR, what is the surgical treatment? Acute severe MR, I have already taught you in the beginning also. These patients, definitely, if like there is papillary muscle rupture, you need to do the reconstruction of the papillary muscle. So surgical correction is definitely required. Okay, surgical correction is definitely required, right? And this mainly if there is papillary muscle rupture. And this surgery, it has to be done within days to weeks. Within days, like the surgery has to be done if it is secondary to acute MR. If it is acute severe MR, secondary to papillary muscle rupture. So that was about the surgical intervention, that is mitral valve repair and as well as the mitral valve replacement. So mitral valve repair, what is that we do? We do the construction of the valve and we do the insertion of the annuloplasty ring. If it is like primary MR, mitral valve repair will be enough. But if it is secondary MR like ischemic MR, mitral valve replacement is best than compared to that of mitral valve repair. Okay. Now, we have one more important device which has been developed for the treatment of the mitral regurgitation. So that is transcatheter mitral valve repair and replacement. Okay. So that is the clip. That is the mitral valve clip. And this particular mitral valve clip placement it can be done by passing the clip through the catheter, right? By passing the clip through the catheter. So you need to, first same approach like what we have discussed, PBMV. So you need to take the clip in the catheter, puncture your femoral vein, then enter into the inferior vena cava, from there to the right atrium, puncture the interatrial septum, right? And then you cross that particular clip into or across the mitral valve. And you need to apply the clip over the edges of the anterior and as well as the posterior mitral leaflets. So thereby what will be the advantage? Let me tell you. So this mitral clip, right? So this will do what is called TEER. What is this TEER? TEER stands for, T stands for transcatheter, right? There is no much thing in that. But E stands for edge to edge repair. Right, TEER stands for transcatheter edge to edge repair is commercially available for the treatment of, so this is available for both the primary MR and as well as even the secondary MR. We do this transcatheter edge to edge repair. Now, whenever you deploy the clip, right, so the clip is being deployed via the transeptal puncture and this particular clip, it grasps the edges of the mitral valve leaflets. So, which particular part of the mitral valve leaflet is being grasped? It is the mid portion. Okay. So, it is the mid portion. So, A2 component of the mitral valve leaflet and P2 component of the posterior mitral leaflet, that has to be grasped and that has to be, like brought together, and that can reduce the severity of the mitral regurgitation. Right. So that is about what is called as TEER, transcatheter edge to edge repair with the help of a clip. Right. And you have to know like what the studies have shown. So is it like only medical therapy which will be sufficient, or along with medical therapy, if you apply the clip, that will be sufficient. So what studies have shown is the use of TER clip along with medical therapy, that has been found to be more superior than compared to that of medical therapy alone. Okay, so this will improve the ejection fraction of the individual, and that will also prevent the cardiac remodeling, and this will also reduce the hospitalization of the patients secondary to MR causing left ventricular dysfunction. So that is the advantage of TER with a clip device along with the medical therapy, right? So this completes the discussion of the mitral regurgitation. So in a conclusion, please remember the most common cause of the primary MR will be mitral valve prolapse, and the other causes of primary MR will be rheumatic, healed infective endocarditis, then radiation, right? And these are the causes for primary MR. Secondary MR, dilated cardiomyopathy, ischemic cardiomyopathy, atrial fibrillation, and calcification of the mitral valve leaflets. And the acute MR, it could be secondary to coronary artery disease, it could be secondary to the ruptured chordae tendineae, it could be secondary to trauma to the chest, and it could be secondary to infective endocarditis causing perforation of the valve. Then in acute MR, the presentation will be sudden onset dyspnea. But whereas in case of chronic MR, if it is only severe MR, then the individual will become symptomatic even at rest. That is in the form of dyspnea, fatigue, and they will also develop palpitations. And on examination, auscultation is very, very important, where the individual will have a pansystolic murmur. And if the anterior mitral leaflet is being affected, the murmur will radiate to the axilla, and if the posterior mitral leaflet is affected, the murmur will be radiating to the base. And the important first line investigation will be your 2D echo, right? And in the treatment, first medical management, if the individual is refractory to medical management, then surgical treatment. So in the surgical treatment also, if it is primary MR, repair is best then compared to that of replacement. But if it is secondary MR like ischemia causing MR, then replacement is best then compared to that of repair. And the new approach is the application of this TER clip, right? That has been found to improve the ejection fraction of the individual and reduce hospitalization of the patient. So this completes the discussion of the very important topic, that is mitral regurgitation. Thank you very much.